I have a few questions before I get started. Among the Taiwanese delegation, how many of you are physicians? Raise your hand. Probably about a third? Probably about a third? Yeah. I'm just trying to get a sense of the audience, and also trying to make sure that we have appreciation of kind of the types of people who are coming to hear this. I've been working in long-term service and supports for over a quarter of a decade, for a quarter of a century is what I want to say, over 2 decades, and have had a kind of a trajectory that started out very 50,000-foot research-oriented, doing microsimulation models, projecting costs, figuring out what policy changes, effects might be. And along the way, got the opportunity to be supporting new initiatives and new innovative programs where they're trying to, organizations on the ground are trying to implement a new policy, a new program, and providing technical assistance to them. And so that movement from sort of this level to the practical level and where people are implementing and the challenges they encountered was very eye-opening. When you're kind of at the high level, you go, well, why don't they do it that way? It just makes sense. Well, there's a lot of reasons why people don't do things the way you might think makes sense. And it has to do with sort of the day-to-day operations. It has to do with the manner in which information is provided to them, what they're working with, a number of different things. And so what I want to try to do in the course of my time here is to kind of walk through not kind of what's wrong with the US or what might you learn from that, but kind of glean some of the things out that if I were to get to start from scratch, what I would recommend. So that's my goal here. And so it's kind of keys to success at sort of the front end operation level. In terms of finding those who might need long-term care, in terms of intervening in critical pathways. So people are on a journey to long-term care usually, and there might be points at which it makes the most sense to try to give them different types of either information or services that you might be able to either prevent them from going into crisis or make their journey a little less bumpy. So that's around timely information. Conducting assessments, Barb talked a lot about the CARE tool and sort of the components of that, and so I want to talk a little bit about that too. Targeting services, again, sort of along this pathway, there might be places where it's most appropriate to do certain types of things, and focusing on that. And then coordinating the various supports and services, care management types functions. So Josh showed sort of how people with functional limitations among the Medicare population are much more likely to have high medical expenditures or average medical expenditures. This is a slightly different look. This is looking at the proportion of people who are in the top 5% of spenders. So this is the high users. And so 1 is basically 5%, the general population. And along the bottom here, you probably can't read these, but are different combinations of chronic conditions, multiple chronic conditions, and functional impairment. And it shows the relative probability of being in that top 5% as you have these different conditions. So everybody on the far left is 1. If you don't have any functional limitations or chronic conditions, you only have a 0.2%. You're only 20%. 0.2% as likely to be in the top 5%. So you're much less likely to be in the top 5% if you don't have any of those things. And it kind of moves up. When you get to 1 chronic condition, 1.8 times as likely to be in the top 5%. 2 chronic conditions, 3 chronic conditions. It's when you start having functional limitations, when your chronic conditions, almost everybody who has functional limitations has multiple chronic conditions. And it's so when those, but not everybody who has multiple chronic conditions has functional limitations. And it's when those functional limitations start impacting your daily life is when you go to the doctor. is when you end up in the hospital, is when, it's those, that's the point at which you start getting very expensive. You end up in those high expenditure categories. And so one of my messages here is we need to be, the US is not very proactive about finding people who need help. It's very reactive. It's like you have to go seek long-term services and supports. You have to know where to go and who to find and how to access the system and figure that all out by yourself. In a better system, I would argue that in a routine medical visit, that a physician could identify, this person has a functional limitation. I need to put that in their record because they're much more likely to be one of my high spenders. It would be a very simple thing, but because functional limitations sits in this system of long-term services and supports or long-term care, and chronic conditions and diagnoses and procedures are over here in the acute care system, nobody thinks to do it. It's not part of the routine. It's not part of the operations. It's not part of the care. So one of the things that I would highly encourage you to do is consider something simple. Do they have trouble walking? Mobility, something very simple, something that's not complicated for a physician to figure out, and just flag it in your medical records. And I was reading stuff, you have predictive modeling and all sorts of things going on with your electronic health system, and I would bet that would enhance your ability to target your services appropriately. On the sort of the long-term care side, having that infrastructure to respond to people who seek assistance, but also being able to reach out. So having the outreach so people know where to go and who to talk to. In our system, it's pretty complicated because as the prior speakers have said, it's very fragmented and, these ADRCs, the Aging and Disability Resource Centers, and the No Wrong Doors, we have a separate system for people with developmental disabilities. We have a separate system for people with mental health needs. We have a separate system for people with more physical-oriented needs. Trying to bring those all together after the fact has been what we've been doing for the past 14 years with the Aging and Disability Resource Centers. And so you have the opportunity to kind of start with all of them. I don't know what your systems are already in place, but to kind of craft it so that they're all together at once, all at the table. Because one of the lessons we've learned with the Aging and Disability Resource Centers is there was a requirement that they start with people 60 plus and at least one other population with disabilities. And because it was new and mostly it was aging focused agencies that were doing this to start with, they started with aging and then one other population, and kind of left out these other ones. They weren't at the table to begin with, and that was not a good thing. We're now 14 years later, and we're still trying to convince these other population groups, yes, this was meant for you, and you should have been at the table to begin with. It's sort of a hindsight. Where am I? The interventions, so the critical points, the interventions between one setting and another, and I understand you don't quite have the range of settings we have yet, but it might be moving that direction. Those handoffs and those interventions, those changes, those are very important points at which, electronic medical record and that information will help, but to make sure that both the patient and the individuals that the information who are being handed off to care for in another one have all the information that they need. Helping people make decisions. I know part of the concern is you've got a lot of unpaid help, families helping people, and you want to continue to support that, but people need help making decisions as to what's the right way to go and how can they best use their resources. For example, in the United States, people sometimes by default end up in a nursing facility because families assume that's the safest place for people to be. They're going to get the most comprehensive care, but that might not be the most economical for the family, nor the most desirable on the part of the patient, or the person. Try to make your access to your public programs simple. We have a very convoluted, complicated system to get access to public programs, and so, if you've decided who should receive public services, don't make it a challenge for them. Oops, did I get all of them? Yeah, and then, help people use their own resources wisely, and that will make things stretch farther. In terms of assessments, there's a number of different functions for assessments. One's for screening for eligibility, or screening for whether or not they might be appropriate for certain services. Another is for eligibility determination. Are they actually eligible for a particular program? You can use the information from assessment to start building out a care plan or support plan. You can use that information to decide how you're going to allocate your resources. You can, have higher payment amounts for people with certain combinations of conditions and functional limitations, and lower payment amounts for somebody who may not need as much care. And you can also use it for quality and outcomes if you're doing them on a regular basis. So your functions for your assessments and how you choose your assessment tools and what you want to assess is important. So this kind of mimics what Barb had. I think the one area that she did not include is economic resources. So if you are going to do a fee scale where you pay more if you have more economic resources, that would be a domain you would also include in an assessment. Some other aspects of an assessment, the CARE tool is very medically oriented. And I would recommend that you think of an assessment from a strength-based approach. What are the individual's strengths, as opposed, you also should document their deficits, but what are their strengths? And this gets to more of a person-centered approach, and something that probably Kevin will speak to. So, what is it that the individual needs, and what is what are their desires? How do they want to live their life? As opposed to kind of what's wrong with them and how can we address that? Both are important, but I would encourage to think in terms of strength-based. And then, obviously you're moving to this electronic shared, and so having that assessment information in there also will be very valuable. So in terms of participant choice and pursuing kind of personal goals, this concept of person-centered planning. In the United States, it comes out of the developmental disabilities community, where the advocacy and the strength of that community relative to older adults is pretty dramatic. It's parents fighting very hard and very vigorously for their children, usually, and even as they age. So in this focus, it's around the consumer defining, and it kind of gets at some of the concepts also used in something like chronic disease self-management, if you guys are familiar with the Stanford model. It's the individual sets the goal, and if I'm setting the goal, my goal is probably not to get my blood pressure down. My goal is probably, to be able to see my daughter get married, or, something that is much more practical and personal to me. And if you start putting what people are doing around their health and how they live and their choices around how they're going to be able to get to their goals of what they want to do in their life, you're much more likely to get compliance. You're much more likely to have somebody who's participating in their care. And so if you take this person-centered approach and the whole team, which is, your specialist, your primary care, your home health aides, whoever has to interact with this person is all aware of this, they can gear their messaging, they can gear the supports they're trying to provide, they can gear the motivational aspects of what they need to do in order to get the person to do what they need to do around their health in that way. And so this is a very specific tool. I can provide you more information about it, but I encourage you to think about it. The other piece is, and some of the prior speakers mentioned this, sort of providing the right service at the right time. And it's a challenge. You have to know a lot about a person, and you have to catch them at the right moment. And so what you really need is sort of a range of interventions, evidence-based interventions, and I know you base a lot of what you do on evidence-based, that can get at, people who really need an intense and are at high risk, maybe need some types of interventions that are very different from someone who's sort of at the initial stages of having a functional limitation and kind of needs to be more preventive types of things to keep them from getting worse. And again, so jealous of, sort of your cloud structure that I think if you had between the assessments and some decision algorithms, it would make it easy for the clinical folks to or even a non-clinical folk to be able to know from an algorithm behind the scenes, here are the things that we might want to discuss with this person in terms of different types of interventions that we could pursue that would help them. And again, allowing for that flexibility to meet the individual needs, and always remembering to include the caregiver and the family in these decisions. In the US, we have all these laws around the privacy and the medical records and other sorts of things that are almost to the point that they push the family away because it's the individual has to consent to this. And most of the time when the individual is very sick, they're not in a position to hear and understand and digest what you're telling them. And so the inclusion of the family is absolutely important. And I figure you all probably already know that and do that. In terms of coordinating supports and services, we were kind of talking at the back table back there a little bit. To the extent that you can, start with the default as the community. That's where people want to be. They don't want to be in a hospital. They don't want to be in a facility. They don't want to be in a residential care. They would prefer to be home. And if you start that with the default and you gear everything you're doing in the medical and in the long-term services supports and in the post-acute, that's the goal for somebody to be in the community, if it's appropriate and safe and all the caveats, but that's the primary goal of everybody. I think you could have a very different way of structuring what you're doing than trying to flip that like we are in the US. And having it across the different types of services and settings, making your decisions around where is it appropriate public, where is it appropriate private, what's the mix and the co-pays, having it be consumer driven, having the people who are going to be affected by this informing your decision processes. In a lot of the federal efforts and the grants, there's requirements to have people who are receiving the services on advisory groups actively involved in how it's being implemented. And I know Kevin in the participant-directed stuff is very familiar with that and knows kind of how to make that happen well. And again, the family focus. And then the interdisciplinary team. If you can take a team-based approach and have sort of the person who is at the right level, but not necessarily too high level in terms of their training, be the one providing the services where appropriate, but have a team available if something's not quite where it needs to be, that they can call to the people who are at the higher level. That would probably help you with the cost aspects. So my recommendations are applying that system focus, looking at across both systems and thinking in terms of practically how things are going to go from one thing to the next, and really mapping that out, sort of the business process mapping of how things will work and who will do what. And once you do that high level piece, then as you start implementing, you're going to start figuring out, are there staffing decisions that we made that we maybe need to rethink. So being willing to kind of constantly reassess, is this working the way we want it to work, and meeting our overall goals and make those changes. Charting this path to a uniform electronic assessment, I think would be a wonderful inclusion in your cloud. again, sort of that idea of having at least a minimal functional status. So not everybody's going to get this full-blown assessment, but some indication of whether or not somebody might need to get an assessment from sort of regular encounters would be invaluable. And then having that evidence base and developing that evidence base for linking what resources you're going to provide to your desired outcomes, and then that person-centered interdisciplinary approach. So I will stop talking and let you ask questions. And I might get you back on time.
I had no doubt. What excellent. Thank you. This is Dr. Yu. Again, I retired from the medical practice here recently. I think it's point out that this is some of the case we talk about your mental health. Are we providing medical services, or are we providing needed services? I think with the limited resources, as I said, experience, I have some of the experience with the two communities. Mm-hmm. Those people who are medical needed, I was recently provided services helping the social worker and then handling the multiple task force, basically focus on medical special need group people. And mm-hmm. those doesn't cost, actually those people like a mental retardation, and MS people and deafness, blindness, and those veterans who lost their legs and so forth. Those people are active people. Those are people in the community. They can go there, steal grocery, working times. And they most important, they share the housing together and they have a companionship. Psychologically, they are very happy and they work there. They want to be active. They don't have to be in institution. Those are people we should be free out, helping out as a living. That's what I have my experience. Mm-hmm. They're very happy because they go there, they're still working, and the community welcome them. They share the housing, their companionship still functioning well. Why we should use the resources with a less cost. The community, they don't increase, help the social worker. The social worker actually very happy. They still handle other things. They don't have to provide this, the one-stop services. And those have become active. Those are free out of the resources. And it worked perfectly well. Mm-hmm. And resources, I think it's a good point of that. So I wonder what you think about in the future. Those people are medical needed, especially. They don't have to really have to be institutionalized. Right. And you probably know pretty well that to apply for the long-term care insurance is very restrictive.
Oh yeah, they're not going to get it.
Approved.
No.
Even if you have some disease, you won't be approved.
Right.
They end up to be eventually the government going to sponsor. Now, with the financial crisis currently, we just cannot afford with the Medicare, Medicaid, mm-hmm. up to that, how we handle this.
Right. No,
I'm concerned about.
I agree with you 100%. I said, let's start with the community. That's where people want to be and where they need to be. So, yes.
Thank you. Thank you very much. Other questions? Oh, I'm sorry.
Chuck, there's one here too. Yeah. You can walk quick enough.
Yes, I really appreciate you sharing your experience with these so many devices. Can you, because we don't know about your organizations,
sure.
So we don't know how you do in your organization. So can you say something about your group?
The Lewin Group?
Yes.
We do health and human services consulting. It's not unlike RTI. So we do a lot of work with the federal government in terms of research and evaluation and technical assistance, and some work with states also. Personally, me, I've been doing the technical assistance with the Aging and Disability Resource Centers for 14 years now, with the Administration for Community Living, which is a federal agency, but it's the states and local communities who are actually implementing these. And I am currently working on a learning collaborative with the Community Care Transitions Program, which is actually where community-based organizations, a lot of which are ADRCs or area agencies on aging, who are working with multiple hospitals to try to reduce hospital readmissions. And so that relationship between sort of the medical and the hospital and then the community-based organization and how they get access and how they staff and how they do this efficiently and how they do it within the payment that the federal government's willing to pay them has been an interesting journey for the past couple of years for me.
So can you share some best practice scenario for us?
Best practice scenario. So I'm a little at a disadvantage. I was able to, to read some of the background materials, but I feel like I don't have a good enough understanding of what your system is like to be able to provide, practical advice. I can tell you how it works here and what went wrong and what worked well and that kind of thing, but I'm not exactly sure how well that would apply to your system. One of the major lessons learned, as I mentioned, is, sort of within the US, we have sort of a siloed system for even within disability groups, and the fact that the Aging and Disability Resource Centers did not bring everybody to the table to start with, in hindsight, was a big mistake. And it's perfectly understandable why, because it was a lot to take on, it was a lot to chew. It was, primarily aging organizations going, I don't know these other people very well, I'll only take on one. So it's perfectly understandable how it happened, why it happened, but hindsight would be, get everybody at the table to start with. But as we get more information, hopefully through tomorrow, maybe I'll be able to provide a little bit more.
So Josh Wiener, RTI. I wondered if you could speak a little bit more about your experience with the Aging and Disability Resource Centers. And I would be particularly curious to hear more about your thoughts about bringing all of the disability groups into the same organization, which I guess you still need to convince me, because it seems to me that these various disability groups have different needs, different experiences, different delivery systems, different financing systems, and I wonder if a generic, we're everything to everybody organization can work well.
Well, I guess I would argue that it's not a generic we're everything to everybody organization. It's bringing the different pieces together. So, and it's making certain things common. So the way someone experiences intake or, the eligibility process or the assessment process, whether you have developmental disabilities or whether you have a physical disability or whether you have a mental health issue, should be similar. What you ask them about, what you're assessing them for, may be very different. But the experience that they have, the ability to call a particular one number to get the right person on the phone who is knowledgeable enough at least to hand them off to the right person, as opposed to having, no knowledge of the other systems and saying, I don't know. Sort of that, having a processes and sort of the common way of interfacing with people so that their experience is sort of seamless, even though behind the scenes it may not be so seamless. At least in the US, that's the way it works. And we're not 100% there, but I would argue that that is why you would bring it all together, And I think at the federal level, that's where we're at now. The Administration for Community Living is a 3-year-old agency, 2 or 3-year-old at this point. And it started out as the Administration on Aging, the Administration for Intellectual Developmental Disabilities, and the Office for Disability coming together in one agency. So that's very brand new for the US. Just last month, earlier this month, sort of the rehab agency and the independent living centers, so the people who are focused on that, are coming into that same same administration. And so at the federal level, it's being brought together, and the hope is at the state level and at the local level, it can be brought together in a more seamless way. And absolutely, the financing's different. Absolutely, the sort of the way the services are delivered are different. But there are common elements there are common core competencies for the staff that provide services. And there's been an effort within CMS to identify what that common core competency is, so that you have the common core, but then you have the differences where it needs to be different because it's a different population. So I think there is a lot to learn across the different systems, and there's a lot that is similar enough, or at least consistent enough, to make the argument to bring it all together.
I'm Dr. Han from Taiwan.
Hi.
I'm a rehabilitation doctor.
Okay.
And you mentioned about the functional assessment, and you stress strengths-based functional evaluation. But in our experience, patient always complain, I can't do this, I can't do that.
Mm-hmm.
So that, how can you give some example to show how to
do strength-based?
Yeah, how to show the strengths, or is there any available tool to evaluate the strengths of patient?
Yeah, there are definitely tools out there that are more strength-based, so it's a little bit of a process with an individual, and I actually probably wouldn't recommend that's something a physician should be doing. Because it's something that you kind of sit down, you have a conversation, it's extended period of time, and sort of understanding kind of, what does this person do well? What do they think that they bring to the table in terms of what they are able to do for themselves, and then where do they need help? And so it's in that sense, so it's not about kind of what's wrong with you necessarily, but what are your strengths, and what do you bring to the table, and what do you do well? What do you enjoy doing? What do you want to continue doing? That gets, merges over into the person-centered planning part of it too. But there are tools we can refer you to. Go ahead, Barb.
Thank you. This is an area of great development right now in the U.S. in terms of having the person's voice at the table to complement to complement all different
To contribute.
parts. To contribute, thank you, to the input of the person's preferences and goals. So they're all important pieces of information, depending upon, what you're trying to do at that meeting or in that
It can also
stage.
get to the quality piece that Josh was talking about.
Exactly.
Because on the long-term services and support side, on the long-term care side, you may not expect functional improvement. That may not be a quality measure that you would want to try to measure. But whether or not the individual's experience with the service is favorable, and whether or not it's meeting their goals and they're getting to be able to do the types of things that they had hoped to do, that could be a very valuable quality measure.
There's a whole set of work being done on what's called motivational interviewing.
Yep.
And again, I think that Lisa's right. It's typically not done well by physicians.
Not that they can't do it,
Not
but
that
that's
you
not the
couldn't
best
do
use
it.
of their
I
time.
think that there's some docs who could probably do a really nice job of
Yep.
it. But there are tools, techniques, and actually I'll talk a little bit about it just in training, because this is partly how you actually think about what are the competencies of the staff that you have. And this is a big piece of it. And it's not just about patient activation. It's about individual engagement. So it goes way beyond just the person being a patient, because for most of their life, they are not a patient. So.
Oh, okay. Go ahead.
No, I think Dr. Han may have misunderstood the strength. He was referring strength as a manual muscle strength, like a
Oh,
muscle
sorry.
strength, but it's really strength center, meaning overall
person's-
strength of the person.
There,
Yeah. What are the strength of the
Thank
person?
you, sorry. A language issue, yeah.
I just wanted to comment, having spent 12 years as part of the National Center on Aging and Developmental Disabilities, that in our earlier life planning research a few years ago, something that Robin mentioned came to mind, in that When people were doing their IHP process, or individual habilitation plans, which you think about as a way to coordinate and bring together services, one of the things we observed in our research was the staff was perfectly willing to impose all kinds of things on the individual, that the person's preference was overruled many times, and that the real issue is training people to listen and to understand what people want, not just focus on needs.
Right.
Well, thank you, Lisa.
Thank you.
very much.